So this is the part of psychology where we actually talk about clinical psychology or psychopathology, disorders and illnesses, and the treatments and how they've developed over time. So how do you define abnormal psychology? What is neurotypical versus neurodivergent? Well, technically the criteria fall into three categories. The behavior has to be causing a harmful dysfunction. So it has to be distracting or dysfunctional to you. So number one, the behavior has to be deviant, meaning it is not acceptable in that culture. Now, obviously, sociocultural models for acceptable versus unacceptable behavior changes over time, and it differs by culture. For instance, in the Diagnostic Statistical Manual 4, prior to 2013, it still labeled homosexuality as a mental disorder. That designation was taken out in 1973, but not before many LGBT people were quote unquote treated for that quote unquote disorder. One famous example being Alan Turing, the British code breaker who helped break the Nazi codes during World War II. Well, after his illustrious career as a code breaker, he was actually imprisoned for the crime, because it was illegal in Britain at that time, of homosexuality. And one of the treatments that he was forced to undergo was chemical castration. So the idea of what is deviant behavior versus normal behavior, that's very subjective. Women were often subjected to lobotomies for what was considered deviant behavior. That could be like symptoms of hysteria, being too emotional, not wanting to get married. Rose Kennedy, JFK's sister, she was actually lobotomized as a teenager because she was going out and hanging out with guys and breaking curfew. Now, she did have some mental delays due to some really bad medical practices when she was born. Rose Kennedy's mother was giving birth to her at home, and the nurse was there, but the doctor wasn't. The doctor was running late. Well, if the doctor's not there when the baby's born, then the doctor doesn't get paid. So the nurse pushed Rose back into the birth canal and held her there until the doctor arrived, and then he could help give birth to Rose so he could get payment. Well, by being forced into the birth canal beyond the moment of birth, Rose suffered some developmental delays because of cutting off of oxygen to her brain during that birthing process. And so she was very much like a child. She could speak, read, and write in a rudimentary fashion, but, very childlike and was behind cognitively. Well, her father had high political aspirations, not only for himself, but for the male children in his family. And so when she started to be a teenager and was hanging out with guys and socializing with men outside of her family, he had her secretly lobotomized to try to correct what he considered deviant behavior, which actually made things worse for her. She lost most of her ability to speak, read, and move, and had to be put into hospice for lifelong care. So she went from mostly functional to almost completely dysfunctional because of what her father considered deviant behavior that needed to be corrected. So obviously that first criteria, very, very subjective. You've got to be careful with that. The second criteria, if the behavior is maladaptive, if it prevents you from functioning properly. Let's say that you have OCD. Obsessions are thoughts, compulsions are behaviors in response to that thought. And you have OCD to the point that when you drive to work, you are afraid you hit something and you missed it. And so you drive back around throughout the neighborhood looking for whatever it is you think you hit. And then you're always late to work. And you're spending all this gas money driving around the neighborhood. That is maladaptive. If you have a fear of going outdoors and you become homebound because of that, that is maladaptive. It prevents functioning. And the third criteria, is this behavior distressful for the individual? Do they encounter feelings of shame or guilt or discomfort as a result of the behavior stemming from this disorder? Now, obviously, some people with personality disorders are not going to feel any guilt or shame or discomfort over their actions. For instance, if you fall under the category of antisocial personality disorder, that's when you think sociopaths with their cousins, psychopaths, who are more violent. Those are the ones that you think of like serial killers murdering and eating people. So if a person is suffering from antisocial personality disorder, they don't feel shame or guilt. They're incapable of feeling shame or guilt or empathy. But their behavior may very well be maladaptive and deviant, even if they personally are not distressed by it. You technically only need one of these criteria to define behavior as abnormal, and thus potentially relating to a mental health diagnosis. But it's important to note that there is some subjectivity in this. Now, we all have bad days. We may all have behaviors that are deviant or maladaptive or distressful to us, but that doesn't necessarily mean that we fall under the spectrum of disorders. There's a difference between feeling depressed and being clinically depressed. Are you responding appropriately to the situation that calls for you to be sad? Or are you consistently and constantly sad and unable to function? Okay, so drawing differences between normal and abnormal behavior. Now, early on in history, prior to the 19th and 20th century, treatment for mental disorders was a bit archaic, maybe even against the Geneva Convention. In ancient times, like with the Greeks and the Romans, mental disorders were thought to be tied to the cycles of the stars and the moon. Mercury's in retrograde or whatever it is. Hence where we get the word lunacy. Luna referring to the moon. So the idea that there were cycles in the sky that were regulating mental disorders, evil spirits possessing a body, imbalance of humors in the body, if you go back to ancient Greek and Rome. And that led to some very interesting treatments for these mental disorders. For instance, the belief of, if someone's having a seizure, then they're possessed by an evil spirit. Then they might hold an exorcism. They might restrain the person, beat them, castrate them, drill holes into their head, perform lobotomies, which remember, lobotomy is putting an ice pick-like tool in your orbital lobe there, and then moving it back and forth until your frontal lobe is cut off from the rest of your brain. Yeah, it's not very surgical. It's straight up, we're going to hammer a pick into their face and then just swipe it back and forth and then pull it out. So you can see why Rose Kennedy did not benefit from that treatment. The ancient Romans, dating back to Hippocrates, thought that the source of illness was imbalance in humors. And so they would try to drain those humors or rebalance them. Holes would be drilled into people's skulls to relieve the pressure, which I kind of understand. I've had some headaches where I'm just like, there's too much in my head right now. I need to drain some of this out. But I never went so far as to be like, okay, time to drill. But that was the early response to mental illness, or the idea that there were evil spirits trapped in your skull. And so they had to make a way for those spirits to come out. Now, we have evidence of people surviving these treatments and undergoing multiple treatments because their bodies, their skulls, have shown evidence of regrowth around the holes in their skull. So these treatments weren't always deadly. Yes, that's how Athena was born. She was it a headache that Zeus had? And then someone split open his head and Athena popped out fully formed and was like, what up, goddess of wisdom? I love owls. Some other treatments for mental illnesses included institutionalization. Today we call that inpatient treatment, inpatient versus outpatient. Outpatient is more conventional, like you may see a therapist once a week or once a month or what have you. You may go to the doctor to get antidepressants. That's outpatient. Inpatient is when you're institutionalized on a mental health ward. Some barriers to inpatient treatment and institutionalization is the expense of institutionalization. Some people pay up to $600 to $900 a day being on a mental health ward. And so that can be a big barrier to getting treatment. Often without coherent strategies for treating mental illnesses, people that were going through symptoms of mental illness were often restrained to prevent harm to themselves or to others. So this is where we get the idea of asylums being formed. And they would be very crowded, very unsanitary, and life expectancy and quality of living in those institutions was not very high. Then we get to the 19th and 20th centuries, where the medical model, the biological model for psychology emerges. This biological approach believes that instead of evil spirits making people have disorders, instead there's an internal organic cause, maybe a tumor in the brain, maybe a genetic predisposition to schizophrenia, maybe an imbalance in neurotransmitters like dopamine and serotonin. Because of this medical model, they said, well, if the cause is medical, then the treatment can be medical. We can prescribe serotonin and dopamine and lithium and all of these different medications to help mitigate the symptoms of these disorders rather than locking people up and castrating them and lobotomizing them. So this helps to improve conditions in the hospital and the quality of life for those who are institutionalized. However, it's very limited in its interpretation of different factors that result in mental illness. So it tends to focus on the biological and ignore the sociocultural or the behavioral or the cognitive. So this doesn't necessarily mean that the biological approach has all the answers, but this is the main approach that's used today. And it's a bit more humane than what we've seen in the past. So with the arrival of medication and the medical model, we're going to see a trend towards de-institutionalization, meaning the closing of asylums and instead moving patients from those institutions to live with their families and get treatment, or in another controlled, more humane environment like a community-based environment. And so psychological disorders started to become treated with prescription drugs. Now, some of those prescription drugs were hit or miss. If a woman was experiencing hysteria, they might load her up with benzos, which could lead to a full-blown addiction. Cocaine and heroin and morphine were often early drugs used in medical treatments. You could get heroin as treatment for coughs. So yeah, they're like, maybe this is not the best treatment. Yeah, they're not coughing anymore, but they're also addicted to cough medicine. So the medical approach isn't 100% always going to have the answers, but it's definitely a move in the right direction. Here we see the first antipsychotic drugs at the peak of institutionalization. Then we see a slow decline until Medicaid and Medicare makes those antipsychotic drugs more widely available. And then we see a steep decline in inpatient care. Most of our mental health care in this country is going to focus on outpatient care, which is cheaper and less involved. So remember, how do we determine a disorder? Well, these disorders can run a spectrum from being mildly inconvenient or dysfunctional to extreme symptoms that prevent functioning. Now, everybody has these behaviors to one degree or another. Just because you're anxious before a test does not mean you have an anxiety disorder. Just because you jumped when you heard a loud noise does not mean you have PTSD. Just because you really like forks to be separate from the spoons in the dishwasher, that does not mean you have OCD. So you have to have multiple symptoms in a checklist of criteria in order to fulfill those diagnostic models. Once that behavior starts to interfere with your life, that's when it's a disorder. If you're so nervous that you can't leave the house, that's a disorder. If you're so OCD that you can't touch anything with your hands, so you're turning off lights with your feet, that's a disorder. So when it becomes an interference to your day-to-day life. Disorders are unjustifiable. So try to remember this mnemonic device of UMAD. And by unjustifiable, I mean irrational. Like phobias. Phobias are irrational fears. If you have a fear of cars and it's an irrational fear, then you can't be around them. Or if you have a fear of going outdoors to the point where you can't go outside because you think something terrible is going to happen, that's unjustifiable. Maladaptive. This is when it's harmful to yourself or other people. Atypical. It's deviant in that culture. It's not considered culturally acceptable for you to turn off light switches with your feet. So that could be a symptom of a disorder. And distressing. If it's disturbing the person emotionally and they want to find a cure for it or they want to find treatment for it, then it can be classified as a disorder. But not everybody who has a disorder seeks treatment for that disorder. So how do we determine if someone has a disorder and what that disorder is? Well, we have a handy dandy manual. The American Psychiatric Association, the APA, compiled over 400 different disorders into one book. And we are currently on our 5th version of this model, the DSM-5. That was published back in 2013. Every therapist, every psychiatrist, every psychology student in grad school has to have a copy of this book. It's very expensive. It's like $150 because it's used as a tool in order to diagnose people that you may be seeing as clients. And they revise it constantly. We've had 5 different versions, so we've lost some diagnoses that are no longer relevant, and we've added diagnoses that are currently relevant. For instance, homosexuality was taken out of the DSM as a disorder in 1973. Binge eating disorder was added to this recent DSM-5. Gambling addiction was added to this recent DSM-5. Video game addiction So as times change, so does the DSM. Now, it's important for them to add these diagnoses as they come along, as they become more common in society, because a lot of US insurance companies will not cover a disorder unless it's in the DSM. So let's say in the DSM-4, before 2013, you had a gambling addiction. Well, your insurance wasn't going to pay for treatment for that addiction because it wasn't in the DSM-5 until after 2013. If you have anorexia or bulimia, they may treat that, but the insurance company will not cover binge eating because it wasn't a part of the DSM, not until it was added in 2013. So it's important that they keep an up-to-date manual because of how it affects the US insurance system and treatment for those disorders. Now, the DSM-5 is not the only manual that's used. This is the primary manual used in America. The World Health Organization also issued the ICD 10th edition. The ICD is the International Classification of Diseases and Related Health Problems. We're just going to call it the ICD. But we focus on the DSM-5, and there is some overlap between the two. The ICD-10 is just the international version. So what does the DSM do? Well, it tries to describe disorders, but it doesn't give a list of causes. It doesn't say, oh, well, they're anorexic because they must have experienced childhood abuse, because then that might limit diagnoses. If someone's checking off, okay, here's criteria for OCD, they do this, that, and the other, but I'm looking at the causes and none of them apply, well, then they must not have OCD. That would limit people's diagnoses. So they describe the disorders without saying, oh, this is the cause of those disorders. This also helps to predict the future course of the disorder. Schizophrenia tends to worsen over time, especially without treatment. And so it could list future symptoms that someone may start to experience 5 or 10 or 15 years down the road. And that can affect any possible treatments possible for that disorder. Now, the DSM-5 does recommend treatments or suggest them, but it doesn't pinpoint one treatment above all others. Why do you think that is? Why does the DSM limit itself to merely suggesting treatment rather than dictating a treatment?
Because each case is specific.
Exactly right. And we know that there are different psychological perspectives. A psychoanalytic approach may focus more on internal drives, like id, ego, superego. The cognitive approach may focus on irrational thoughts. The behavioral approach may focus on the environment. Some people may do well with therapy. Some people may do better with medication. Some people may do great with exposure therapy, where they're desensitized to their fears. Other people, it might make it worse. So you can't have the one-size-fits-all treatment for the disorders. You have to be able to think outside of that box to try many different perspectives for the possible treatment of those disorders. But in terms of diagnosing the disorders, the DSM-5 tries very hard to be empirical, to be scientific. Hence why they establish operational definitions. They define the behaviors explicitly so that when therapists and psychiatrists go down the list of, okay, here's the symptoms for bipolar, it says they must check 5 out of these 9 criteria, or they must check 3 out of this column and at least 1 out of this column to make it as scientific as possible. And those criteria are based on observable behaviors. So if someone abuses animals or kills animals from a young age, if they lack empathy towards somebody else or towards anybody else, if they're a compulsive liar, well, then you're going down the checklist for antisocial personality disorder. Now, if one person's just a compulsive liar, then that's not enough to meet the threshold for antisocial personality. So you have to have multiple criteria in order to meet those operational definitions. Then you can move on to progression and treatment. Now, obviously, we have a lot of different perspectives that can have a lot of different ideas for how this disorder manifested itself. If you look at the psychoanalytic perspective, that's Freud and Jung and Adler. They believed that the disorders were caused by internal, unconscious drives. You have your unconscious, your conscious, and your subconscious, your id, your ego, and your superego. You repress things and suppress things. How do you fix these disorders? Free association. You do free association therapy in order to explore your subconscious and unconscious mind, to bring those things to light. The humanistic approach believes that every human wants to be self-actualized. They want their real self to overlap with their ideal self. That's called congruence. If they become incongruent, that means their real self gets further and further away from their ideal self. And that's what leads to dysfunction. You're out of touch with your feelings and you don't reach your full potential in terms of self-actualization. So how do you treat that? Unconditional positive regard for that individual, meeting Maslow's hierarchy of needs for that individual. The behavioral model is going to say, no, we don't care about feelings. We don't think about subconscious or internal drives. We think about the external. The environment determines who you end up being. Tabula rasa, environmental determinism. And then you're either rewarded or punished for behaviors, and that's going to result in you repeating behaviors or extinguishing those behaviors. So looking at your reinforcement history, what behaviors have been promoted and what behaviors have been punished, and how your environment has led to the development of a disorder or certain behaviors. The cognitive model is going to say, no, you need to think about thinking. Do they have irrational or dysfunctional thoughts or phobias that prevents them from functioning in society? The sociocultural model says that it's not the individual that is dysfunctional, but rather the society is dysfunctional. And in trying to engage in that society, they have committed some dysfunctional behaviors. So instead of focusing necessarily on genetic factors or the medical approach, they may focus on socioeconomic status. If someone's suffering from PTSD due to violence against women, they're going to look at the patriarchal society. If someone is suffering anxiety and depression, they could look at racial background and racism in the culture that they live in. But again, the sociocultural model can change over time. Some things are considered deviant at one time and acceptable at other times. For instance, in the 1960s, smoking was common. It was not deviant. Women smoked, men smoked, old people smoked, young people smoked, and they did it everywhere. In the teacher's lounge, in the bathrooms, in the restaurants, in the bars. And doctors even promoted smoking as a healthy way to relax. Like they would have commercials and have doctors say, 4 out of 5 doctors recommend Camel cigarettes for a nice break after a long day. Nowadays, not socially acceptable. You can't smoke indoors. You can't smoke on work premises. You don't really see people smoking cigarettes anymore at all. It's a different sociocultural model. In modern times, we can advocate for women's rights and believe that women should have the right to vote like men. In the 1920s, that was not the acceptable sociocultural model. Women were in prison for protesting against their lack of suffrage. They were force fed when they went on hunger strikes in prisons fighting over the right to vote. So this could lead to the disorders coming from a dysfunctional society, gender roles, racial roles, sociocultural models that lead to dysfunctional behavior. The biomedical model obviously is going to be the medical approach. There are internal organic problems leading from genetic predispositions, hormone or neurotransmitter imbalances, and the best way to treat that is through medication. And then, of course, the biopsychosocial model. This is the combination of the medical approach, the behavioral approach, and the cognitive approach, as well as society. So it combines all of those together to be interlocking causes of disorders. So obviously, the DSM is not going to be able to pinpoint just one possible perspective to treat a disorder. There's going to be multiple perspectives that could play a role in the treatment of these various disorders. But there are some disadvantages that come along with the DSM and the labeling of disorders. That line between what is normal versus abnormal is a very hazy line. It depends on the generation. It depends on the time period. It depends on the culture. Also, you may have one therapist who diagnosed you with ADHD and another therapist that diagnosed you with PTSD. Completely different letters, because there could be some overlap in some of the symptoms. So reliability is still a big problem with the DSM-5. If 5 therapists examine a patient, are they necessarily all going to come up with the same diagnoses, or could they come up with 5 different diagnoses? Well, it's very subjective. And this is very important because remember, U.S. insurance companies will not pay for treatment unless it is codified in the DSM-5. So you have to be diagnosed by an official party from the official manual in order to receive treatment. Also, the DSM is overly biological. It focuses very heavily on the medical model, and it may tend to ignore the sociocultural model. So it leans people towards one perspective or another. Another big issue is that mental illness stigma still very much exists in the world today. And once you've labeled somebody with a diagnosis, this can often lead to further stigma, shaming, or avoidance of treatment due to the stigma. It can also create a self-fulfilling prophecy, as discovered by Rosenhan. He had a theory that once you're labeled with a disorder, people will continue to treat you as if you have that label, even if your behaviors are not at all related to that label. To test this theory, he got a bunch of students and colleagues to go to a mental hospital and be admitted after reporting hearing voices. And then once they were admitted, they were to go back to acting normal to see how the hospital staff would react. Would they release them and say, no, this is just a one-off thing? Or would they continue to see symptoms of schizophrenia just because they had found out one symptom at the very beginning at intake? Well, it turns out that once the patient started acting completely normal, the hospital staff still continued to label them with schizophrenia and saw their behaviors through the lens of problematic or maladaptive behavior. So, for example, one guy was just writing in a notebook, and a hospital staff member said, yeah, he's got some pathological writing behavior. And you're like, I'm just writing things down. And he's like, no, they're crazy, trust me. And so labeling and the stigma of mental health can actually perpetuate more shame and less treatment for that. Source, trust me, bro. It's funny. All right, so if the DSM doesn't label causes for mental disorders, then how do we determine what led to neurodivergent behaviors? Well, it's not as easy as saying this was the one event, this is the one thing in their life that led to this disorder. Like, oh, they have a genetic predisposition, or, oh, they experienced a traumatic event. It's usually a combination of interlocking events and effects that lead to disorders. The biopsychosocial perspective says that it's a combination of your genetic predisposition, your physical state, your bodily state, your psychological state, and the stress that you experience, and the society in which you live. Obviously, if you're lower on the socioeconomic scale, you're not having all of your basic needs met, there's going to be a higher level of stress. That could aggravate a pre-existing disposition towards a mental illness and thus trigger the development of that disorder. So it's a combination of factors rather than just one thing. So this is where we see that cycle. Say, for instance, with the biological model, you have a predisposition to depression, psychological trauma. You lose somebody that you love or you lose your job. Sociocultural, your role as the head of the family. Let's say you're male. Well, in patriarchal male standards, men aren't supposed to show emotions. It's seen as weak. So you may be suppressing your negative emotions, and that only makes them ferment further. So you have the sociocultural effects, the biological catalyst, and stress and trauma that can all combine to create the disorder of depression or anxiety. Now, there are some theories as to what exactly would be the equation for the development of a mental disorder. This is called the Diathesis-Stress Model, also known as the vulnerability stress hypothesis. This says that there are two factors, well, three technically. Your genetic predisposition to a disorder or a disease, and then stress that you encounter in your environment. So if these two things add up together, they can meet the threshold to develop a disorder. Now, if you have a high genetic predisposition, then you don't need as much stress to trigger that disorder. You're already stocked up here. If your genetic predispositions are all fine and you don't have a predisposition to a mental disorder, but then you go through an extremely stressful event, that could meet the threshold. So the greater the predisposition, the less stress needed to trigger. The smaller amount of predisposition, the more stress needed to trigger. But that's not the only factor that can play a role in the development of a mental disorder. You also have protective factors that decrease your chances of developing a disorder. So let's say you have a genetic predisposition to depression, you go through a trauma, but you have a support network that helps protect you from further negative effects of that trauma. That could outweigh the combination of your predisposition and the traumatic event, thus preventing you from reaching the threshold for a disorder. This helps explain why people with the exact same genetic predispositions, like identical twins, don't always necessarily develop the same disorders. The identical twins have the exact same genes, but they could have different factors in their environment, different stressors. So one could develop the schizophrenia and the other does not. You have people that have gone through extremely traumatic situations, but because their genetic predisposition towards PTSD and anxiety was low, the stress did not meet the proper threshold to trigger the disorder, or they had protective factors that help mitigate the stress. So it's diathesis, the genes, plus stressors, the environment, minus protective factors. And whatever you get on the other end is a sum game of yes, a disorder, or no, no disorder. Y'all may have seen in popular media that when someone commits a crime, they can just go up before the judge and say, I plead not guilty by reason of insanity. Well, that's not a get out of jail free card. In fact, insanity isn't a psychological term. We don't use that term, just like saying someone's crazy like that. No, we don't use that term. We use neurotypical or neurodivergent to show the normal distribution of these behaviors. Insanity is not one that's included in the DSM. The closest thing you could get to that could probably be psychosis. And so with this plea is applied to someone who cannot tell the difference between right and wrong and cannot control their behavior. It's very rarely used because it's very rarely successful. You could even argue not guilty by reason of temporary insanity. Like if it's a crime of passion, like you came home and your spouse was cheating on you with someone else and then everything went black and red and then you wake up and you like hurt somebody. People who are declared not guilty due to insanity, that doesn't mean that they get to just go home. It's like nothing happened. Oftentimes they will be incarcerated, but instead of being incarcerated in a general population or in a prison, instead they'll be institutionalized in a mental hospital until they're deemed either fit to serve out their sentence in prison or until they're deemed not to be a threat to society anymore. And so if you're declared not guilty by reason of insanity, you could actually spend more time in an institution than if you had pled guilty and gone to jail. So let's say you got a sentence of 5 years, but you pled not guilty by reason of insanity. Well, they may keep you in that institution for 20 years because they can't determine whether or not psychologically you can be released back into the general population. Now, being declared insane is not the same as being declared not competent. Not competent means you're unable to understand the charges. You're unable to assist in your own defense. So like a 3-year-old child, they would not be able to assist in their own defense. They don't understand what a judge is or what's going on. They're just like, why am I sitting here? So oftentimes they will get a guardian ad litem who's supposed to argue on their behalf for them, and that child doesn't have to be present in court. But a lot of times pop culture is going to get these kinds of things wrong. Like one of the biggest flaws is that mentally ill people are violent. In actuality, people with mental illnesses are more likely to be victims of crimes rather than perpetrators of crimes. But you wouldn't know that from watching media or TV shows like Criminal Minds. You think, oh, okay, so this must mean that they're going to be violent. Well, not even all sociopaths engage in violent criminal behavior. I have a lot of videos posted in Schoology for y'all, and they're so much fun. I mean, this one's okay. This one's Hank Green. But the other videos I have are like actual case studies where it'll show an individual with OCD or it'll discuss PTSD. One video that I'm really interested in is the kind of VR experience for what schizophrenia is like, but you don't need the VR glasses. It's just a video where it takes you through the symptoms as if they're happening to you. And so I have a lot of these really awesome videos because I really enjoy this unit that I would encourage you to watch. And this is going to be one of them. This is the one that just covers the general idea of psychological disorders and how they're diagnosed and what are some symptoms. So we talked about how the psychiatrists and therapists use the DSM-5 to help diagnose and to come up with a treatment plan for a disorder. Okay, so those are some of the advantages of a diagnosis. It can help communication. Okay, you actually know what it is that you're going through. You can find support networks online. You could Google. If it has a name to it, that's comforting in and of itself rather than just trying to Google symptoms. Because if you've ever Googled symptoms, WebMD tells you that you're going to die in 7 days. So a lot of anxiety there. If you just know, oh, well, this is why I have manic stages and depressed stages is because I'm bipolar, and the treatment for that is lithium and cognitive behavioral therapy. That kind of eases some of that anxiety over the maladaptive behaviors that may be causing you stress. It can also provide etiology. This is the study of how this disorder manifested. Like we saw that certain risk factors for certain disorders could involve the environment with parenting, or examples of early onset abuse like with anorexia or with bulimia. And so while the DSM-5 doesn't say definitively this causes that, it does kind of leave you breadcrumbs to kind of build an idea of how did this disorder manifest. Is it biological? Is it environmental? Is it both? Or is it related to trauma? It also provides not only a diagnosis, but also an outcome. So if you're diagnosed with schizophrenia in your 20s, then you can see what could happen if you are leaving it unmedicated or untreated in 10 years versus what are the antipsychotic medications that you could use to help mitigate the effects of those symptoms. And that helps to give direction for a treatment plan. Now, the DSM doesn't say this is the only way to solve bipolar, or this is the only type of therapy that works for OCD. It has a wide berth of treatment plans that may differ according to the person and their symptoms. And so some people get discouraged when they're trying to find a therapist or they're trying to go through therapy, they don't click with their therapist. Or when they first get on a medication, they don't feel different or they have side effects or symptoms. Well, that's because it's not an exact science. You may have to go from one antidepressant to another antidepressant until you find one that works best for you. You may have to go from one therapist to another therapist to find one that works for you. We're going to be responsible for knowing the 10 different categories that are going to be tested on abnormal psychology or neurodivergent psychology. We have anxiety, which obviously could include phobias and OCD and PTSD. That OCD and compulsive behavior deals with phobias and anxiety. And so they do separate them in categories, but I kind of just like combine them together because they're so closely related. But we're going to talk about like generalized anxiety disorder and panic attacks, moving into OCD and other compulsive behaviors regarding phobias, then trauma and stress-related disorders like PTSD. Then we'll move into motor disorders, which can include things like Tourette's syndrome, which isn't just people randomly cussing or yelling bad things. It can also include facial tics or random words. Like there's one woman in a video that I watched on Tourette's where she just says biscuits over and over again. It's like every 2 words, she's just like biscuits, as opposed to someone else who says some very, very inappropriate words. And he's just like, I can't help it because of the Tourette's. And so you can see how that could impede their day-to-day life. Somatoform disorders dealing with not necessarily hypochondria, but more so when you have a physical malady that resents from something that's purely psychological. Like y'all may remember in the BBC, British Broadcasting Company's version of Sherlock Holmes, John Watson walked with a limp after he came back from the war, and it wasn't because he actually hurt his leg, but it was because of trauma associated with the war. And so we'll see how that manifests itself. Dissociative disorders, that can be dealing with fugue, where you forget who you are and you start a whole new life because you have no identity of like who you were before the fugue hit, or amnesia. It can also relate to a response to trauma by disassociating from the situation and not being mentally present. Mood disorders, that's going to deal with bipolar disorder or borderline personality disorder. Schizophrenia, that can lead to psychosis, but there are other symptoms that we're going to learn about with schizophrenia. Personality disorders, that's a fun one, like histrionic personality disorder or narcissistic personality disorder, antisocial personality disorder, which doesn't mean, oh, they're introverted and quiet. It means that they literally don't adhere to the laws and rules of society or social cues. So that can include sociopaths, and there's a small subset of them that are violent known as psychopaths. Then lastly, with the factitious disorders, that deals with like hypochondria, Munchausen's by proxy, the idea of becoming sick for attention or having too much anxiety surrounding illness. And so you assume that you actually have a genuine disease when really it's just self-propagating anxiety.